All right, so that brings us to ditch the drip. So Dr. Rebecca Salvo will be talking about PPI drips versus IV bolus of proton pump inhibitors. This comes up a lot in the ICU. The gastroenterologists frequently recommend IV drip or continuous infusions of protonics for people with peptic ulcers and GI bleeds, which never really made a lot of sense to me pharmacokinetically because most of these agents the duration of action is more than 24 hours. So I didn't really understand why we need a continuous infusion. And so that's the origin of the topic, and we'll find out if it's real or a myth. Dr. Salvo.
Thanks, Dr. Fried. Like you said, I'm Rebecca Salvo. I'm one of the internal medicine interns, and I'm going to be talking to you about whether PPI drip is better therapy than IV bolus for peptic ulcer bleeding. So just a little introduction about peptic ulcers and upper GI bleeding in general. So the upper GI bleeding prevalence is about 170 in 100,000 adults per year, with an annual cost of about $750 million. Peptic ulcer disease accounts for 50 to 70% of acute non-variceal upper GI bleeding, with mortality rates ranging from 6 to 8%. The predominant risk factors, I think, as most of us know, are H. pylori and NSAID use, and treatment primarily consists of eradication of H. pylori if that is the cause with antibiotics or with acid blockers. And the mainstay now is proton pump inhibitors. So just to kind of review how proton pump inhibitors work, they're actually a prodrug that are weak bases that accumulate and activate in the acidic environment of the parietal cell. So once it's in the actual parietal cell, it's converted to a cationic tetracyclic sulfonamide, which covalently bonds to the alpha subunit of the potassium hydrogen ATPase, and that causes suppression of acid production. However, the proton pump inhibitor actually only binds to the active pumps, which accounts for about 70% of what's of the actual pumps in your stomach. So at one time, not all of the pumps are actually inhibited. And then interestingly, one single dose does not, it's not interesting, but you would think one single dose doesn't profoundly decrease acid, and it takes about 5 to 7 days if you're just taking one dose daily for it to reach steady state, and of course as you increase, that time will decrease. So what's the theory behind using PPI in GI bleeding? So gastric acidity is thought to play an important role in the pathogenesis of rebleeding. So both acid and the pepsin in the stomach are thought to produce decreased coagulation effects by interfering with both the intrinsic and extrinsic coagulation systems, fibrinogen polymerization, and platelet aggregation. So at a lower pH within the stomach, acid and pepsin actually digest clots, so that is obviously not what we want in a GI bleed. But it's also thought that if you have a persistent intragastric pH greater than 6, it can help prevent bleeding. And that would be attained by blocking acid. So I already went over how the PPI works, but the hypothesis is because the elimination half-life of the PPI is about 1 hour, that a constant infusion of the PPI is required to maintain that intragastric pH greater than 6. So what are the current recommendations? These are the recommendations from the American College of Gastroenterology, last updated in 2011. And what they recommend for patients with higher risk stigmata or known bleeding is to possibly use pre-endoscopic 80 micromilligram bolus followed by the standard 8 mg per hour infusion of PPI prior to endoscopic therapy. However, this has been noted not to improve clinical outcomes, so that's kind of a moderate recommendation. It's not necessary. They do recommend having an EGD within 24 hours of presentation, and then based on what they see on the EGD kind of dictates how further treatment will be used. So if the patient has active bleeding, a non-bleeding visible vessels or adherent clot, receive endoscopic therapy, so that includes electrocoagulation, the use of a heater probe, sclerosant, or clipping, and that's always followed by the IV PPI bolus, the 80 milligrams, followed by the continuous infusion, again, the 8 mg per hour. If they have flat spots or clean-based ulcer, that can usually just be treated with an IV bolus or oral PPI. And then if they have recurrent bleeding, then they go back for endoscopic treatment. But where do these recommendations come from? So when I was doing my research, PPIs weren't actually approved in the US until about 1990, and the most recent study, or the first study that I could find in terms of looking at the continuous infusion was in 1997. And all the studies prior to this 2011 recommendations that I could find was actually just a omeprazole infusion versus placebo. But in both of these studies, they used the first study here was actually just in elderly patients. The age was greater than 60 who presented with ulcer bleeding. No endoscopic treatment was used at that time, and they compared the infusion versus a placebo, and they found that their outcomes of overall survival, rebleeding, and need for blood transfusions and mortality were all significantly better in the continuous infusion group. And the same was true for this second study. The only study that I could find, or Dr. Fried actually helped me find, comparing a omeprazole infusion versus bolusing after endoscopic therapy was this single set institution study in the British Journal of Surgery. It was a study of 122 patients who were randomized either to what they called the standard dose, which was just a 40 milligram IV bolus daily, or the high dose infusion, which was the IV omeprazole 80 milligram bolus followed by the continuous infusion, both for 72 hours. And what they noted was that actually only 3% of the high dose group exhibited rebleeding versus about 15% in the standard dose boluses. So their conclusion was that the IV standard dose omeprazole was inferior to the high dose omeprazole for preventing rebleeding after endoscopic hemostasis for peptic ulcer bleeding. And this was the only study I could find showing this. But what other studies have been done to compare? So this is a study done in the Journal of Digestion, which was comparing the intermittent versus continuous pantoprazole infusion in peptic ulcer bleeding. So this study consisted of 329 patients with active peptic ulcer bleeding or a non-visible vessel who were initially treated with endoscopic therapy and then randomized either to get the IV bolus 40 milligrams twice daily or the bolus plus the continuous infusion, both again for 72 hours. And what this study noted was that in just the bolus group, the 40 milligram, the rebleeding rate was 6.1% versus 8.3% in the infusion group. The duration of stay was also a little bit lower, as well as the need for blood transfusions, and the need for urgent surgery was about the same. So what they concluded was that the intermittent and continuous pantoprazole infusions after successful endoscopic therapy have comparable outcomes, but they noted that intermittent administration has the advantage in cost and application. And I actually looked up, just for you to consider, what the actual cost of these are. And so the cost of the 80 milligram bolus plus the continuous infusion for 72 hours is about $450. And if you're just doing the 40 milligram IV bolus twice daily, it's about $38. So just something to think about. And this next study was studying the effect of pantoprazole drip versus bolus on stigmata of recent hemorrhage among patients with non-variceal bleeding. So this was a smaller study. It was 35 patients who were randomly assigned to either do the recommended bolus and infusion versus, again, 40 milligrams twice daily. And then this was pre-endoscopic treatment. And then EGD was then performed. And what they noted was there was no significance in the stigmata of recent hemorrhage, the rate of rebleeding, or need for surgery or mortality. Again, this paper also brought up the significant cost saving in terms of their effectiveness as well. This study, very similar randomized study. It was a large study, 482 patients who either had the active bleeding, non-bleeding visible vessel, or the adherent clot, who were initially treated endoscopically and then randomized to receive the infusion, the bolus infusion, or 40 milligrams. This one was daily. The bleeding recurrence and the infusion rate was 11% versus 8.1% in the bolus group, and that was significant. And the mean units of blood transfused in the infusion was 1.7 versus 1.5. Length of stay was less than 5 days, was 37% in the infusion group versus 47% in the bolus group. And there were also fewer surgical interventions needed in the bolus group. The conclusion for this paper was following endoscopic hemostasis of bleeding ulcers or standard dose PPI bolus was just as effective as high dose regimen in reducing the risk of recurrent bleeding. Still going for you, got more. This study, another similar study, but this was actually specific to patients who underwent endoscopic submucosal dissection. So that is a procedure for superficial gastric ulcers where initially the GI physician will go in endoscopically. They put a little fluid in this case it was saline and epinephrine and some to kind of elevate the tumor, and then they go in and cut it out, and then this procedure often results in ulcer formation. And so they were looking at how the treatments with PPI would affect ulcer formation, rebleeding, and what they did was after patients underwent the submucosal dissection, they were randomized and either assigned, again, the infusion versus 40 milligram twice daily. And they looked after 72 hours what the risk of what high risk stigmata they showed, or if they had any delayed bleeding. And the conclusion for this one was that the incidence of delayed bleeding and high risk stigmata were not affected by the PPI infusion method. They did note, kind of based on the morphology of the lesion, could need closer monitoring, and they noted that if it was a depressed lesion after the dissection, they would need closer monitoring, but the PPI didn't affect that. So this is the last study I thought was kind of a good wrap up. This was in JAMA. It was a systematic review and meta-analysis of 13 randomized trials of patients who were endoscopically treated with high-risk ulcer bleeds, and then again comparing the dosing of PPI and currently recommended regimen of the bolus plus infusion. And if you can kind of look at this table, what it's showing is that the risk ratio were all less than 1, which indicates that there's no increased risk with the intermittent therapy. All of the studies in this, all the trials in this study demonstrated non-inferiority of rebleeding at both 3 and 30 days. And an interesting thing that they also looked at was the proportion of time that the pH was greater than 6. And it was virtually 100% for both. So as I spoke about before, that the theory was the infusion was better at keeping the pH greater than 6, which is why it was thought to be a better therapy. But what they noted was that it was actually equivalent in this study. Similar conclusion, intermittent PPI is comparable to the current guideline recommendation of IV bolus plus continuous infusion of PPI in patients endoscopically treated for high-risk bleeding ulcers. And I thought you might be wondering, well, what about orals? How does that compare to the IV? So I found actually 3 different studies that compared oral versus IV pump inhibitors, and they actually all showed that they all demonstrated similar effectiveness in terms of peptic ulcer bleeding, but the studies had some issues in that they were not powered to prove equivalence or non-inferiority. So I think larger randomized trials are needed, but another thing to think about. And that is it. Those are my references. Any questions?
Okay. Anybody have any questions, comments? Dr.
I
Litton?
think even if the oral versus IV hasn't been studied against one another very well, individually, the oral versus placebo, I think, has results very similar to IV versus placebo, and it's 90% bioavailability. So I think your myth ought to be, is IV continuous any better than oral?
Well, I think the point is, like I said, this comes up a lot on rounds in the ICU. A lot of these people, some of these people, you can't really, they're not able to take POs because they're critically ill, at least the ones that I see or that we see in the ICU. Some of them can, and certainly that it would possibly be an option, but there are only those few studies that have really looked at it specifically for this, active bleeding, treated or untreated. So I'm not saying that that isn't a possibility, but there's actually at least excellent data that you don't need to use a drip. One of the problems with the drips there are two big problems. One, obviously, is the cost. It's more than 10 times more expensive. And that's the cost to the hospital that she gave you, I think, not the cost to the patient. And in general, the patients are charged 10 times what the hospital cost is for most drugs. So that means the $450, the cost to the patient would be more like $4,500 versus, probably $300 for the bolus method. And maybe, I don't know how much, probably half that or less for the PO if they were able to do the PO. Yeah.
Yeah, but you're going to go years before finding anybody who's in the ICU and either does not pay anything or is not med deductible. So I sort of say
that's true. But, at the very least, the cost of the hospital is 10 times more. And the other thing is that sometimes they don't have access, so they don't have enough access. So we end up having to put in extra lines just to accommodate a continuous infusion, which you wouldn't have to necessarily do if you had a bolus. So that's the other problem that we've encountered. So those are the two main issues, and I think to me it's pretty clear that we don't need to be doing drips. I don't know why the gastroenterologists continue to recommend that. At least most of them do. The guideline was from 2011, and the only thing I'm going to say about that is one of the authors of that guideline was an attending at USC when I was there. He was one of the co-authors of the ACG guideline. The meta-analysis that she showed that was published about 2 or 3 years later, he was a co-author on that. And in that meta-analysis, in their conclusion, they said the guideline should be revised because there's no real data. So even the experts now, I think, agree that this is really a myth. So, but what do you guys think? How many people think people think that we should just keep doing infusions and it's just as good? How many people think it's plausible, and how many people think it's a myth? All right, well, it's pretty clear cut. So unlike some of the other ones that we've done, it's not a lot of controversy. So, busted.